Good. So we are 3 times grateful to Janet for having accepted to give this lecture. The first reason is that this is the 15th lecture of the Rodolfo De Benedetti lecture, and for us it means something. I think you have a full list of the previous lecture, so I think to have reached the 15 is for us very important, and we were really looking for a distinguished speaker for this lecture, and the fact that Janet agreed to give it is for us a great honor. The second reason why we are so grateful to her is the fact that she chose as a topic an issue which is of utmost importance, and indeed it is attracting a lot of attention also. Besides the people who are here in presence, there are many other people who are following us online. There are 3 keywords in this lecture that seem to us to be extremely important. The first one is child. If you look at the list of the previous lecture of the Rodolfo De Benedetti series, inequalities is a term that comes out, and most of this lecture deal with inequality. Clearly, equality of opportunities is a key issue, and social mobility, and clearly these things can be addressed when you look at the situation of the well-being at early childhood. The second term is mental health, and this is a very important issue, and one that is increasing in importance. During my previous life, when I was working at the Italian Social Security, there I was observing indeed an increase in the extent of mental health diseases at all levels with respect to other type of disease in the Italian population. So this is really getting a very important topic in its own right. And the third one is human capital seen from the health perspective, and that's also very important for us because I believe that more research should be done at the border between labor and health, economics, and there is really a lot we can learn at that intersection. The third reason, and perhaps is not the least important, for being grateful to Janet, is the fact that she decided to be here in presence. And I have to say that I've been looking at some of the interaction between Janet and Roberta Marcaletti, who is the main organizer of these events, and the amount of paperwork Janet had to go through to be able to be here with us is incredible. So really, thank you so much for being with us. Rosanna Tarricone will now clearly talk about the contribution Janet to research, and so I don't need to go through this. The only thing I want to say is that if you look at her CV, it's amazing the extent of the public service activities that she did. And this is not a sign only of the fact that Janet is a good citizen, but you can see simply by looking at the number of responsibilities she took in the university she was working at, so that's an indication of this civicness, I would say. But it's an indication of impact of research because, being called for hearings, being called in committees, deciding upon very important things is a sign of the fact that your research is really something that is deeply thought as being relevant and important, and I think that's a very important, and it's very rare, especially for people having a record of publication in scientific journals as Janet has. So I don't want to take any more of your time. I now give the floor to Rosanna, and then we will have the lecture. Just one thing to organize ourselves. It would be better to keep the substantial questions after the lecture. But if you have specific issues that you do not understand or technical things to ask related to some slides, you can raise your hand. For those who are instead following online, everything is done at the end. At the end, you will be able also to ask questions from remote. Okay? So thank you once more, and the floor is yours.
Thank you very much. Thank you very much, Tito, and first of all, a good afternoon to everybody, colleagues, friends, students, ladies and gentlemen. I have been given the privilege to introduce Professor Janet Currie and her work on mental health and children. And I have to admit that condensing in 10 minutes the work by Professor Currie and trying to introduce her, it was, quite a difficult task. So for this reason, I decided to take some notes because, it is really difficult, to condense in such a short time all that Janet Currie represents for the scientific community, but also for the policy-making community. So, Janet Currie is a health economist. She's currently professor of economics and public affairs at Princeton University's School of Public Health and International Affairs, where she's also director of the Center for Health and Wellbeing. Janet starts her studies in economics at University of Toronto, and then she moved to Princeton University, where she received a PhD in economics. But later on, she also received her honorary doctorate at University of Zurich and doctor honoris causa at University Jean Moulin at Lyon. Janet has served in several other academic institutions before joining finally Princeton University, and all these academic institutions represent the most prestigious ones in the United States. She was the first female chair of the Department of Economics at Columbia University, and before Columbia, she taught at the University of California, Los Angeles, and at the Massachusetts Institute of Technology. Janet has received multiple honors and has been awarded prizes almost for everything. For excellence in the mentoring of PhD students by the Columbia University, for her mentorship of younger economists from the American Economics Association. She has been named one of the 100 alumni of influence by University of Toronto. She has been recognized for outstanding refereeing by the Journal of Health Economics, and she has been named one of the top 10 women in economics by the World Economic Forum. She's member-elect of the National Academy of Sciences and has received the Nomis Foundation Distinguished Scientist Award, just to name the few. Professor Currie co-directs the program on children at the National Bureau of Economic Research. She's currently on the board of the Coleridge Initiative, of the Environmental Defense Fund, of the New Jersey Integrated Population Health Data Project. But Janet also serves on the advisory boards of a Blue Health Intelligence, Behavior and Inequality Research Institute in Bonn, and of the Opportunity and Inclusive Growth Institute at the Federal Reserve Bank of Minneapolis. She served on the board of reviewing editors for Science magazine, and currently serves as associate editor for the Journal of Population Economics. Professor Currie has previously held editorial roles for numerous highly prestigious economic peer-reviewed journals, including the Quarterly Journal of Economics, the Journal of Health Economics, the Journal of Public Economics, the Journal of Economic Literature, and the Economic Inquiry. And I just summarized. There are others. Janet counts over 150 scientific publications in highly prestigious outlets such as Annals of Political and Social Science, Health Affairs, Review of Economics and Statistics, Health Economics, Science, Journal of Economic Perspectives, Journal of Health Economics, Journal of Labor Economics, Journal of Human Resources, Journal of Economic Perspectives, JAMA. Professor Currie's research has marked a milestone on the impact of poverty and government anti-poverty policies on the health and well-being of children over their entire life cycle. Beginning in the early 90s, she was one of the first economists to evaluate such programs from the point of view of the child. She has written about early intervention programs, expansions of the Medicaid program, public housing, and food and nutrition programs. She showed that children in a Head Start make gains relative to their own siblings in terms of test scores and longer-term measures of attainment. She has showed that expansions of public health insurance to low-income women and children improved access to care and reduced infant mortality. Professor Currie has investigated the broader socioeconomic determinants of fetal and child health, including healthcare, child maltreatment, nutrition, environmental threats, maternal education, and smoking behaviors. She has shown that inequality in mortality is falling among US children, at the same time that inequality in mortality among adults has been increasing, and she has attributed this improvement to the protective effect of safety net programs and wider public health policies. Overall, her work works that early childhood, including the fetal period, is of great importance for the development of children's productive capabilities, the greatest human capital for all societies, and that programs targeting early childhood can be particularly effective in balancing out childhood disadvantage. Her work has supported the development and improvement of health policies in terms of coverage expansion, and has highlighted how opportunistic behaviors can be limited by more effective reimbursement schemes for the sake of better health of children. Janet Currie is a strong advocate for mental health, especially because it is usually overlooked when compared to physical health, although it is among the most common chronic conditions affecting young adults, and not only in US, but also in this corner of the globe. Mental health is one of the most important determinants of adult working days lost, and more in general of adults' attainments. In fact, she says many non-cognitive skills that economists have linked to success in the labor market can be directly affected by mental health problems. Although scientific research and medical innovation have greatly improved mentally ill patients' health outcomes, there are very rarely mental health disabilities that are easy to treat in children, and especially in adolescents, what she calls the missing middle years, when many mental health problems are first diagnosed. For this reason, Professor Currie urges further research into the effectiveness and cost-effectiveness of treating mental health disabilities in adolescents. Janet Currie is a prominent economist, a tireless scholar who has hugely advanced economic knowledge in this field. But this is not all, not in her case. Her mentoring students and young scholars has ignited their passion and enthusiasm. Her service for public institutions has helped transfer academic research into better health policies. Her availability and openness to work with international academic institutions has helped grow global awareness around the issue of inequalities of access to care. But to me, Janet is also something else. Janet is a role model. And we are deeply honored and proud that you accepted our invitation. And the floor is all yours. Thank you very much.
Thank you. I have to say how delighted I am to be here. This is the first post-COVID live talk for me. A little bit of an experiment, even whether I could get here and get over all the obstacles. And so, yeah, I'm just really thrilled. So, as it's been said, my topic for today is child mental health as a form of human capital. And so just starting from the basics, what is human capital? Well, one dictionary definition would be that it's a form of wealth that's embodied in people. And historically, economists have spent a lot of time thinking about human capital predominantly as it's measured by education, sometimes looking at training on the job as another measure of human capital. But increasingly, health is being recognized as an important element of human capital, and within that category of health, people have been focusing on mental health as particularly important. So mental health problems are something that's important for children. We think that a lot of them begin even in utero or in early childhood, but then they really become noticed or diagnosed in adolescence. And as was mentioned, they're extremely common. So one estimate for the US is that about a fifth of adolescents will have a mental health problem that causes them some significant impairment at some point during their adolescence. So that rate is about the same as the rate for adults. So this is a really common health condition. And one reason that it's particularly important for economists is that it affects people of working age. So Tito was talking about bringing health into the labor market, and this is one really important area for bringing health into the labor market. So I'm going to talk a little bit more about that connection, and then I'm going to talk about research that's related to the prevention, diagnosis, and treatment of mental health problems, and sort of what economists have learned about that to date. So this is a figure from the OECD. I can't say that I would personally vouch for every data point in this figure, but the point is to compare employment rates for people with depression, which is one of the most common mental illnesses, and people without depression. And so the point is then across these OECD countries, you see much lower employment rates for people with depression than people without. And indeed, countries that do the specific breakdown, like Great Britain, show that mental health is the leading cause of working days lost. And I've boxed Italy here so you can see, and it's basically within the range of the other OECD countries. Looking at the costs of mental health problems, these basically break down into three parts. There's people who don't work at all, people who are less productive when they do stay on the job, and then the direct medical costs that are associated with treating mental illness, which can be also very expensive. And so the estimates, again, from the OECD, is that this is a very significant cost in terms of GDP. So I've done some work looking at long-term effects of mental health problems in childhood on different adult outcomes using Canadian data where we can follow children over time. Canada has the same advantage that a lot of European countries in the sense that everybody's covered by public health insurance, so you can follow people over a long period of time. And just trying to compare, well, what's the impact of physical health problems that are common in children to the impact of mental health problems that are common in children? And so kind of to summarize some of that research, here I'm showing a plot where each data point is a regression estimate of the effect of a diagnosis of a particular problem at a particular age. So the orange line is showing the impact of asthma diagnoses, and the outcome here, I should say, is whether you're on social assistance as an adult. So you can see having asthma has some small impact. Having injuries, and these are serious injuries, also has some small impact on your probability of ending up on social assistance. But the two common mental health problems that I had in this data, ADHD and conduct disorders, have much larger impacts than these common physical health problems. So again, even starting in childhood and looking at different outcomes, you can see that these have a large impact. Okay, thinking about prevention, I would say that the thing that we know the best from research to date is that the prenatal period can be very important for mental health, and so supporting mothers through pregnancy and preventing bad things from happening to pregnant mothers is a good place to start in terms of preventing childhood mental health issues. Some of the first evidence of this came from the Dutch hunger winter. So this was the occupation of the Netherlands during the Second World War, which caused famine in part of the country. The famine was very specific in terms of the time. So it really lends itself to a sort of a cohort analysis where you can look at the cohort of babies who were born before the famine, the people who were affected in utero by the famine, and then the cohorts who were born after, directly afterwards. And what people, Ezra Susser, who's a psychiatrist, observed was that you had a higher rate of schizophrenia in the cohort that was immediately affected by the famine. Okay, so famines are a pretty extreme outcome, and they don't happen every day, and everybody can agree that preventing famine is good. What about more everyday type of problems? So people have done a lot of research using large-scale administrative data sets to look at that. So for example, this paper by Peterson et al. Looks at the Danish data, looks at twins, even identical twins, and shows that lower birth weight twins are more likely to have ADHD as they grow older. And so again, that's pretty suggestive evidence that birth weight can have an impact. A third paper that I really like, using Swedish data, compares mothers who experienced a death in the family during their pregnancy to mothers who experienced a death in the family shortly after pregnancy. So they're really focusing on this severe stress to mothers during the pregnancy compared to just afterwards. And what they find is that the children who were affected in utero by this severe maternal stress are more likely to have ADHD when they're children, and then they can follow them into adulthood. As young adults, they're more likely to suffer from depression. Okay, so we have pretty strong evidence, I would say, from this fetal origins literature that people can be damaged in the womb. Okay, so that's sort of the very depressing side of things. On the more positive side, we also have some evidence that by intervening during the pregnancy, you can prevent some of these outcomes. So in work that I've done with Anna Chorny, we looked at people who participated in a program called the Supplemental Nutrition Program for Women, Infants, and Children, or WIC. And so this is a program you can think of as, it provides a food supplement to poor mothers, but that's in a package where they come and they get maternal care, they get counseling, they get connected with social services. So it's kind of got a lot of wraparound services, where the food maybe is the reason why people walk in the door, but then they get a lot of other things as well. So we looked at mothers who participated during this program during pregnancy at their children at ages 6 to 11, and we compared children whose mothers had participated for them but didn't participate for a sibling. So we could compare siblings where one participated and one didn't. And what we find is that compared to the siblings who did not participate, the ones who received these services were 5 to 6% less likely to have ADHD or other common childhood mental health conditions by age 11. Okay, so these services have become much more widely available everywhere. There's a lot more programs for pregnant women. There's home visiting in some countries. And so you might ask yourself, okay, if we have all these services, why do we keep hearing that mental health for children is getting worse, right? It should be getting better since we have all these programs. Okay? And so I'm going to argue that there's several reasons for that, and that basically it's very hard to tell without a lot of work that we haven't really done yet what the trends are even in mental health. So why is that? First, diagnostic standards for many conditions have changed frequently over time. Psychiatrists have this DSM manual. Over the period of time I've been doing research, we had DSM-3, DSM-4, DSM-5, and the definitions of mental health conditions are some of the things that have changed the most over time. Okay, so just to take one example, for autism, there used to be two different disorders, autism and Asperger's. When they did the DSM-5, they combined those. So now there's something called the autism spectrum disorder. So what that means is that a lot of children who have the autism label are not as sick as the ones who previously had the autism label, but there's many more of them. Okay? So that's one thing, changes in diagnosis. Another thing that maybe concerns economists more are changes in the incentives to screen and diagnose people. So just as an example of that, in the South Carolina data where I was telling you about WIC, what you see is if you look at ADHD diagnosis over the period that we were looking at, you see an increase, which you can see here in the blue line. But if you break that down, it seems like it's all coming from the Medicaid patients, which is the public insurance group. Okay, so the public insurance group, they're getting more diagnosis. The private pay group, they're not getting any increase, right? That seems very strange. So we started looking into, well, what was changing about Medicaid? And the thing that was changing about Medicaid was that over this period of time, most states switched from a reimbursement scheme where doctors got paid for every service that they did, a fee for service, to one where they got a payment, or one capitated payment for each patient. So the key things are that the capitated payment was bigger if the child had a chronic condition, okay? And the capitated payment was reduced if the plan did less screening than the competitor plans. Okay, so they were evaluated relative to their peers, and if you weren't doing the screening, then you got lower payment. Okay. So we look at the effect of this switch in South Carolina, where this switch was phased in county by county. And we have two different ways of doing that. One is to do an event study, so look at all the children in the 2 years before the change in a county and the 2 years afterwards. And the second one is to follow an individual child over time. So the child is always insured, the child always has Medicaid, and the thing that happens is that their Medicaid program changes the way that it reimburses the physicians. So looking at the event study, you can see in the top graph here that you get more screenings when you change the mode of reimbursement. Okay, so remember they're potentially getting penalized if they don't do screenings, so they start doing more screenings. And then you can see the ADHD diagnoses follow right along with the screenings. Right? So if you do more screenings, you're going to find more problems. And that's a good thing, not a bad thing, right? So the rates are going up, but it's because more people are getting diagnosed and treated. And if you follow the same children over time, what you see is that the same child is more likely to end up with a diagnosis of ADHD and depression. Those are shown in the green bars. but also a lot of physical health conditions as well. So asthma, infections, ear, nose, and throat, autoimmune disorders. Okay, so there's like an across-the-board increase. And so you might think, if you just looked at the data, oh, the kids are sicker. But they're not sicker, they're just getting more treatment. Okay, so I want to spend the rest of my time talking about treatment, and this is really current research that I'm doing. One reason for looking at this in a US context is because there's so much variation. So in some ways, it really does serve as a laboratory for trying to see what works and what doesn't work, just because it's so various. So to illustrate that, this is a map where all the little squares here are counties in the US. So there's something like 3,500 counties. And what I've done is to take the data for all prescriptions for antidepressant medications prescribed to 10 to 19-year-olds and just do a heat map. So what you can see is that in some places there's practically no prescribing, the really light colors. And in the darkest colors here, there's almost one prescription per child. And so there's just huge variation in the amount of prescribing that's going on. Okay, so in some work with Emily Cuddy, we try and look at the effect of the mental health treatment that people are getting in a large national sample of children who all had private health insurance. They all had good private health insurance. So this is, none of the differences that we see here are because people couldn't afford to pay for care. And what we ask is how much of the variation in the treatment can be explained by some of the characteristics of the local areas. And two types of characteristics we consider are the supply of providers. So here if you look at the literature, they'll say, oh, well, you know, children aren't getting good care because there's no child psychiatrists. That's a common thing that you would see. So we can look at that. And then the second thing is looking at the practice styles of the doctors that are there. And I'll talk a lot more about what I mean by practice style in a minute. So we're looking at all these different things, and then we use machine learning algorithm to predict the probability of treatment using the area level measures. And then we're trying to use that to examine the impact of the type of treatment that they get. So why are we using the area level measures? Well, to try and get around the endogeneity of the individual child's treatment, right? So if somebody's sicker, they might get more treatment, or maybe if they're a higher SES household, they get more treatment even if they're not as sick. And so what we want to do is isolate the part of the variation in the treatment that's just due to the fact that people in different areas get treated differently. We're going to focus on what we call the first mental health episode for a child. The reason for doing that, there's a couple of reasons. The first is that if you have somebody, say like an adult who's been depressed for 20 years and you observe that they're taking some kind of medication, it isn't necessarily their current doctor who decided on that course of treatment, right? Like once somebody has started down a certain path, you might be reluctant to change it. Right? So getting in on the beginning is a cleaner measure of arguably what the doctor wants to do. Okay. The second thing about looking at the first episode is that the guidelines are a lot clearer about what should be happening. Okay, so here's what we sort of distill from the available guidelines about what should be happening. So the first time a child is diagnosed with a mental health problem, usually they should get therapy before they get drugs. Okay, so you should at least try therapy. Or maybe give drugs and therapy, but they should be having some therapy. Secondly, we argue that the clinician should use a drug that's approved for use in children. Right? And so that sounds kind of obvious, but it's a little bit more tricky than it sounds because there are very few drugs that are approved for use in children. Most drugs, drug companies have to submit an application to get something approved for use in children. That means they have to do clinical trials. It's very expensive to do clinical trials. So many drugs aren't approved for use in children, partly because the company has never submitted an application for that. Then there's some more obvious things, like they should avoid using the older antidepressants that were in use before SSRIs came into effect. The reason for that is because those drugs are much more dangerous, have much more side effects. You're more likely to have overdoses with them. So you wouldn't want to start with those drugs. And secondly, clinicians should probably avoid giving people drugs that are highly addictive and have a danger of overdose. So the biggest class of drugs like that would be benzodiazepines, like Xanax, Klonopin, Lorazepam. Those are some of the brand names that you might have heard of. Okay, so in a minute I'll show you the sample statistics. You should think about a 12-year-old who's coming in with depression for the first time. They shouldn't be prescribing them Xanax, Okay, so the sample we have are children who were observed before age 11. They have a first mental health episode sometime between 10 and 17. We have to be able to see where they are to use this area level idea. We observe them for 6 months prior to the index episode, and that's how we try to tell that it's the first time. Okay? And then we have to observe them for some period of time afterwards. So we have 202,000 children we can observe for 3 months afterwards. If we observe them for up to 24 months, then we lose a lot of kids. So we end up with 97,000. And most of these kids are between the ages of 10 or 14 when they have their first mental health episode. So what do we mean by an episode? Most of these are defined using a diagnostic code. So you have a diagnostic code that says that they have some kind of mental health problem. But we're also including here children who we think have a mental health problem because we see that they're receiving a mental health service like therapy, or they're receiving a mental health drug, even if there's no diagnostics code on the record. Okay. Just as an observation, that 30% of the children in our sample have some kind of neurodevelopmental condition like ADHD or autism. We're not treating those as a new mental health disorder. As I was saying, a lot of those things seem to originate in the prenatal period, and so somebody's born with that, and then they may later become depressed or have an anxiety problem. So we're focusing on the depression or the anxiety problem and not on the neurodevelopmental condition. And so using these definitions, we find that about 9.2% of our sample children have a first mental health spell. And that's kind of comparable to what the Centers for Disease Control says the incidence is in this population. Okay, so what are the main things that we see? This is showing broad diagnostic categories. So I've shaded in orange the sort of depression, mood disorders, which is a big category. Then the yellow, the anxiety disorders, is the biggest category. The green is something called adjustment disorders, which is kind of a wishy-washy category that psychiatrists give you if they're not really sure. So they think there's something wrong, but they don't necessarily want to label you with something serious, so they say that you have an adjustment disorder. So those are sort of the biggest categories. And then you can see that a lot of other things are there, but are quite small, like eating disorders. Okay. Just to show you the geographic coverage of our data, this particular insurance company doesn't insure people everywhere in the country, but it's one of the biggest ones, so it has a lot of coverage in all the areas that you can see in blue. Okay. So then the first thing we did with this data was just to say, okay, well, what kind of treatment are people getting for this first mental health episode? So the pie chart that's labeled 1A shows the broad categories. So 42% are getting therapy, 30% are not getting any follow-up within the first 3 months after the initial episode. And then about 1/5 are just getting drugs. If we look at the people who are getting drugs, just drugs alone or drugs and therapy, what we see is kind of disturbing in that about half of them are getting drugs that make sense. They're FDA approved. They're not including something like benzodiazepines. The other ones are getting things which either aren't FDA approved or definitely one of these suspicious categories or some combination of drugs, more than one of these things. Okay? So on the face of it, it doesn't look like the treatment is great. Looking at the means for this sample, if you compare the first red box there, I'm looking at the whole sample of children. And then the second column is the sample who have a first mental health episode. So you can see that on average, we're following kids from about 7 or 8 years old up until their first episode at, say, age 12. And we see that the kids with mental health problems have higher probability of being hospitalized. They have higher probability of using the emergency room. They have about twice as great monthly health costs. And this is the actual cost that the insurance company is paying plus whatever co-payments the family is paying. And yeah, I won't go through everything else on here. But then I also want you to just look at the last column, which is these kids who are getting these, what we're going to call red flag drugs, so drugs that should raise a red flag. And what you see is that these kids are twice as likely to be hospitalized. They're also more likely to be using the emergency room, and they have the highest monthly costs out of any group. Okay? So this could be because they're sicker, but it looks like they're very high cost. Okay. So I just want to make kind of an aside about this idea of looking at area level variations in care. Since this is not a new idea, there's a lot of research going back a long time looking at this. One of the first papers is this paper in Science by Wenberg and Gettelsen in 1973. Where they showed that there was huge variation in things like appendicitis rates across parts of Vermont. And the conclusion, I'm quoting here from something that Wenberg said about his research, but the gist of their argument was that the differences in the rates are so great that they couldn't possibly reflect differences in underlying health conditions. They had to be reflecting differences in the way that medicine was practiced, and that it was evidence that medicine was not being practiced in a kind of evidence-based way. And this idea has really taken off and been applied in many different places. This is, again, using OECD data, looking at hospitalization rates across countries, and I've boxed Italy. So the idea here is every bar is supposed to be a health region, and the width of the bar gives some idea about the population, and then you can see the differences between the top and the bottom. So actually the one in Italy is kind of compressed compared to, say, England, where you have differences in hospitalization rates going from 5,000 per 100,000 up to 15,000 per 100,000, so a 3 times difference, which seems on the face of it just to be too large to be due to differences in underlying health. Okay. So taking this idea and applying it again to this particular context, I showed you that there was a big difference in prescription rates. There's also, turns out, to be a big difference in what psychiatrists' favorite drug is, if you look across counties. So in this map, I'm just showing you what some of the top drugs are. And you can see there's some pink areas there. Those are, sertraline is the generic for Zoloft. So those are Zoloft areas. And then the light green is the Prozac areas. So depending where you go, where you live, you're going to get a different drug. All right, so turning to the things that I showed you in the pie charts, there's also a lot of variation in those things across areas. So here I'm just showing you the percentiles across areas in how children were treated. And so you can see that there are some areas where no children got red flag drugs. And here I should say I'm chopping out areas that have very few children, so all of these have a decent number of children. So some places nobody got the red flag drugs, and then in some other places all the children were treated that way. Okay? So there's a lot of variation. So then the question is, does this variation explain anything? Does this explain the variation in the individual level treatment? So the first thing that we do is look at the type of treatment that people got, control for things like the child demographics, measures of the severity of the child's illness, measures of socioeconomic status, including area level fixed effects. And then we look at the health market characteristics, so the supply of therapists, general practitioners who prescribe psychiatric drugs, and psychiatrists. And just to summarize what we find there, if you normalize all the data, so the places with the fewest are all at 0, and then you say, what happens if you increase psychiatrist supply, holding the other groups constant? Right? So let's hold therapists constant, let's hold GPs constant, and let's just say what happens if we add child psychiatrists. What you see is actually that you get more kids getting drugs only. So if you think about it, what's special about a psychiatrist, right? Like a social worker can give you therapy, but only a psychiatrist can write a prescription. So you actually see more kids getting drugs-only treatment if you have relatively more psychiatrists. And that red line shows that you get more kids who are getting these red flag drugs if you have more psychiatrists. Right? So it's not the case that the problem here is that there aren't enough psychiatrists. And you also see that the pink line is people getting therapy and drugs. The green line is people getting therapy only. The more psychiatrists you have, the less likely the kids are to be getting therapy. Okay? And then the reverse is true if I do the other thought experiment and say, well, let's hold psychiatrists constant and add therapists. Well, then you see more kids getting therapy. So the supply does matter, the composition. Okay? But it doesn't matter a whole lot, in the sense that it doesn't explain very much of the variance. Okay, so here the first row is saying, if I just control for the child's effects, how much of the variance do I explain? Then the second row says, if I add in these supply side measures, how much more do I explain? Hardly anything more. But the area, something about the area really matters, because the third row says, if I put in area fixed effects, how much do I explain? I explain a lot. Okay, so there's some fixed characteristic of an area that really matters. So the next thing we look at are these measures of practice style, like what, which is the bottom part of this table. What's the share of the mental health providers who are psychiatrists? What's the share who are primary care physicians? What's the share of a primary care physician's patients who receive mental health drugs? So like how much of this prescribing are primary care physicians doing? What's the share of provider prescriptions that are for these red flag drugs? Okay. And as I mentioned, you can't assume that treatments are randomly assigned. So we're using these measures of practice style, interacting them with measures of the severity of the illness and other characteristics of the child, which yields many potential instruments or predictors of treatment. So we use machine learning to select a smaller vector of instruments that are the most predictive of each treatment. Okay, so here, something like the share of providers in your area who prescribe red flag drugs is very predictive of whether you get a red flag drug, not surprisingly. Okay. So then the outcomes we look at, first we look at spending, which is a natural thing for economists to look at. Then we also look at whether patients went to the emergency room or were hospitalized, which are important outcomes for the patient. You know, you don't want children going to psychiatric hospitals. And then we look at 3 months, 12 months, and 24 months out. Okay, so what do we find? If you look at these red box estimates, what they show is that if you get treated, costs are higher. That isn't surprising, right? You're spending money on treatment. But what it does say is that spending money on treatment initially is not saving you money 2 years down the road. Your costs 2 years down the road are still higher. What about facility use? You also see that treatment is actually associated with more facility use, so more people going to the emergency room, more people being hospitalized for more days. Okay, so that's not looking so good. Then if you look at within treatment, saying, okay, you got treated, did you get drugs or did you get therapy? So therapy alone is the default here. And if you got treated with drugs, your costs are higher. Your probability of visiting a facility is initially higher as well, although there's no effect on number of nights in the hospital. And then we ask, well, if you got drug treatment, does it matter whether you got one of these red flag drugs? Okay? And so what you see for that is, I think, kind of interesting because your mental health costs are initially lower. So one thing people ask me is, well, why would anybody give kids these drugs? Okay. Well, if your initial costs end up being lower by giving kids these drugs, that would be one reason why they get prescribed. Okay. But then your costs, your total health costs after 2 years are actually higher. Okay. So you have a trade-off here where in the short run, they might think that they're doing a good job, but in the longer run, it doesn't look so good. Okay. And then looking at facility use, we see that a lot of this increase in cost seems to come from increases in the use of emergency rooms. So people get these red flag drugs and they end up having bad side effects or having other complications and ending up in the ER. Okay, so we kind of summarize all that in a tree where we're going through each step of the decision making here. Okay, so if you start at the top, you have, well, did you get treated within 3 months? Yes or no? If you got treated, you have higher costs. Okay. Well, if you got treated, did you get drugs? Yes or no? Okay. If you got drugs, you had a lot higher costs, like twice as high. But then you can ask, well, if you got drugs, did you get these red flag drugs? Okay. And it turns out that a lot of the higher cost of treatment is associated with these red flag drugs. Okay. So in the end, if you got one of these red flag drugs, you have a cost of $9,653, whereas if you got drug treatment but you didn't get a red flag drug, your cost is closer to $4,000, so less than twice as great. Okay, so a lot of these higher costs of drug treatment are due to this suspicious drug treatment. And looking at facility use, you see a similar sort of pattern where a lot of the higher facility use is due to these red flag drugs. Okay, so just to offer some conclusions then, what I've shown you is that there's a lot of variability in treatment. It's not very well explained by area variations in the supply of mental health solutions. So just training a whole bunch more child psychiatrists is not necessarily going to make things better. Variations in practice style between individual doctors are also very important. Having any treatment in the first 3 months after an initial episode seems to increase costs over the next 2 years and facility use. Also conditional on any treatment. Drug treatment is a higher cost thing than therapy. People often talk about how therapy is expensive, but the costs associated with the drugs seem to be higher over this time horizon. And those negative results of drug treatment are largely driven by these questionable red flag drugs. So what that suggests is that adherence, even to the kind of loose guidelines that I showed you are out there, would considerably improve matters. Okay. And I think what's interesting about that is that the discussion about guidelines is often, doctors getting upset because they think people are going to try and tell them what to do, like you should give this child this drug. And the guidelines that I showed about sort of eliminating extreme outcomes would still improve things a lot without being really prescriptive. So then sort of an overall summary is that mental health may be one of the most important aspects of child health. It seems to have greater effects than a lot of physical health problems. And so I think what that means is that there's an urgent need to better understand the determinants of treatment and also to promote compliance with guidelines in order to get better outcomes. So.
So thank you, Janet. This was a fascinating presentation. So I must say that I'm involved quite a lot with the chairing sessions where you present papers lately, because you were at the European Economic Association in another session on mental health, and another paper actually on postpartum and depression, so not children, but mother this time. So this very active research that you have, very interesting as well, and very powerful and very, I think, topical, because there's also more and more interest in mental health, and especially, I think there's a lack of evidence in children, as you point out. So I just had a number of questions actually to you, some directly on what you presented, but maybe a bit more general, actually based, you touched on that in some of your papers, which I also know about. So we talk about children, and one of my first questions was, so the mental health originates, so you pointed out in the womb, but probably also within the family. And so the broad question is whether the family is part of the solution or part of the problem itself. Okay, so you alluded to investment, and in one of your papers you have actually production function there with a positive or negative investment. And I was wondering if you had any thoughts about this heterogeneity and probably lack of awareness in a number of families, because these issues are still not very well discussed and known. So that could be one big difference, especially across SES groups. There's also presumably, as a parent myself, too much pressure, and that's probably actually maybe in the high SES group at this time. Too much pressure to achieve, setting the bar very high, and this is all this literature about helicopter parenting, which may actually have spurned mental health issues by locking in children and imposing a lot of things on them. And then there is something which is even more taboo, but which is coming out now, which is essentially child abuse within household, which is direct harm, incestuous behavior, and there's more and more evidence that this is actually quite widespread. It's very difficult to measure, very difficult to say anything about that, but indirect evidence shows this is actually a huge under-researched issue. So the essential, how should we, as economists, write down a family model where you have a production function in there? Is that how should we start about thinking about the family itself as presumably the first place where these children are growing up? So that's one question. Is pretty broad, so feel free to pick what you want there. But the second one is if we're still talking about families, differential effect by gender, daughters and sons, and what's the role of fathers and mothers specifically, or it's not necessarily the same. So fathers and sons and daughters and mothers are bonding in different ways. So this is something I've been interested in. I did some work actually on looking at that, not so much on mental health, but very indirectly at looking at deaths within the family, whether fathers and mothers, and how that did for daughters and sons. But there's also this interesting aspect of mental health and these shocks, not only in utero, but how that essentially transmit into later outcome. And so the last, because we're talking about family, which is a very open question, is what does divorce do to children? Is it beneficial, perhaps in some cases, or detrimental to their mental health? Okay, so I think that's essentially the set of questions related to family. Maybe I'll let you answer to that, because that's already plenty.
No, I was thinking I need a piece of paper to write them down.
I can send that.
But I think you're totally correct about the central role of the family, and it's something that I think as economists we've sort of neglected, because our whole paradigm is very individualistic. And with respect to mental health, the thing is that even if the family is part of the problem, the social agencies still have to work with the family, because the family is the only game in town, right? Like it or not, or competent or not, the family is going to end up providing most of the care for the child, right? So if you don't work with the family to try and help them to do a better job and get their cooperation to do that, then you're not going to be able to do a lot for the child, right? So your alternative are you take the child away, which is very extreme, and we know that that doesn't lead to very good outcomes, or you try and help the family help the child. And to do that, you have to make an ally of the parents. And right now, I think the system usually doesn't do that. It usually makes sort of, even high SES parents feel like they're being told that they're a bad parent all the time, right? And so that doesn't help to improve anything. The child abuse issue that you raised, I think, is really also important and vastly under-researched, partly because of data issues. There's some really interesting work using big data to try and identify children who may be being abused. It's very controversial because, there's so much stigma obviously attached to being labeled as a potential child abuser. But I've done this myself using hospital discharge data. It's when I first started in the research that I mentioned, looking at child injuries, I sort of thought, well, child injuries should be pretty random. They're not random at all. So there's some children who show up like in every 6 months period of the data with an injury, right? So you look at that and you think, okay, there's obviously something wrong here. Either the child is being abused, or they're not being properly supervised, or it wouldn't be happening that they're injured in every single period of the data, right? And so these kind of things do stand out, and there is some possibility to, screen on those kind of measures if we could find some beneficial way to do that. I think that would be very interesting. And then you ask about divorce. I think, back in the days when the laws were being liberalized, there was a lot of discussion that divorce might actually be good for children, get them out of a conflict situation and so on. That was probably kind of optimistic, or just that's what people wanted to believe. I don't think there's very much evidence that divorce is generally good for children. But on the other hand, it's one of those genies that's not going to go back into the bottle. So it's not really clear as social policymakers that there's a lot we can do about that particular issue.
Yep, so there are a few questions actually on the, I'm not sure you see it, but Franco Peracchi had essentially the same question with differences in mental health problems between dual and single parent families. I think we touched that, but
some of the research, I'm sure you're aware of this research, is interesting because it's suggesting that fathers are particularly important for boys, which maybe is consistent with this whole literature about male fragility. You know, males die at higher rates at every age. And so, you know, I guess if you have a tail of the distribution that has some very vulnerable boys, they may be more subject to shocks like not having a parent around.
We have a question from Pietro Biroli, who's asking about stigma and the importance of stigma in across the space or geographic variation in treatment. So if you could say anything more than that or not.
Yeah, so stigma is tremendously important. You know, preventing people from getting treatment still, I think it's reduced a lot over time, and I think it's another thing that could be driving higher rates. So especially, actually, you know, one post-COVID thing that may come out, there's been a lot more discussion about mental health and, you know, that lots of people are suffering mental health problems. You know, perhaps that will cause people to be more open in future about discussing mental health. I do think the stigma is gradually reducing and that is causing, you know, more people to be diagnosed with mental health problems.
There's a question there, yes.
Thank you very much, Janet. The findings of your research have a lot of implications in terms of policy, you know, health policies, or also, you know, in terms of, you know, how to manage, you know, these diseases. And something that I'm really interested in is whether you also collected the outcomes of all these patients, you know, children. Because, you know, it's very interesting when you say that not only we do have variation in practice within different, you know, segments, you know, for instance, amongst psychiatrists, you know, there are variations in terms of the types of drugs that are prescribed, but there are also variations in terms of, you know, how many children got therapy and drugs, how many only therapy, how many only drugs, which is, I mean, another meso level of variation, which also reminds me that, you know, although we are very, you know, we are very keen in assessing the comparative effectiveness or cost effectiveness within, you know, the same therapeutic area, we are not so keen to assess, for instance, the cost effectiveness of different models of care. So is it better, I mean, to go only for psychiatrists and medications, or is it better for the children in terms of health outcomes to go for, you know, therapists, you know, without any medication? So going back to the question, do you have also the data on health outcomes, or are you aware of, you know, whether these different practices have also, you know, investigated, you know, the better outcomes for these patients?
So I guess that's in part what I'm trying to do in the paper that I talked about at the end. In the sense, you know, you're following people for 2 years, and then one sort of summary measure of health is how much they ended up spending on health subsequently, right? Or did they end up getting hospitalized? Did they end up going to the emergency room? So I didn't emphasize it when I was going through those trees, but what it looks like is that the people who get a reasonable drug, let us say, do as well or better as the people who get therapy only. So the thing that sort of popped out of the data was not that therapy is better than drugs, which is kind of honestly what I expected going in. But the thing that popped out was that getting these drugs that don't follow the guidelines is bad, and all the other care is better.
So I was just thinking whether this reflected teaching hospitals kind of school of thoughts of practitioners who were trained in particular areas and perhaps sent to different counties, or some kind of a spillover or kind of peer pressure or peer kind of decisions of doctors, or so what have you looked at that?
Yeah, I think that's a really a natural next step is to say, you know, which doctors are not doing such a great job and what are their characteristics. So the kinds of things that you can look at with doctors are, you know, where did they go to medical school? Maybe where did they do their rest of their training, their age, their gender, things like that. So you don't have really detailed information, at least I don't have really detailed information, but some things I can say are that doctors who went to better medical schools tend to do a better job prescribing. I've looked in some other work at opioid prescribing. The same doctors who prescribe a lot of opioids also prescribe a lot of benzodiazepines, sometimes to the same patient, which is very bad. So you can see correlations there. Another thing that seems to be going on with respect to children is that there's different guidelines for drugs for children than for adults. But there's some doctors who treat children as if they were adults. So they have their favorite drug that they prescribe to everybody, and it doesn't matter what the age is or if it's appropriate for a child or not. So there's a lot of correlation across ages in the kind of prescribing that people are doing.
Hi, thank you for your presentation. And I have just a curiosity, and it's about like nursery schools. I was wondering whether you were able to check whether the children in your sample actually went to nursery, and whether like the mental health diseases varied across like children who went to nursery schools and children who didn't. It's just a curiosity because I know that in the United States it's like public nurseries are like you can go only if like the parents are having a job, so it's not as easy as maybe it is here to go to nursery. So I was wondering whether there was some correlation.
Yes, so I wasn't able to do that with any of the data that I was talking about today. There's a nice paper by Sherry Gleed looking at the introduction of universal preschool in New York City. And one of the things that she finds is that there's an increase in diagnosis of learning disabilities and some other mental health conditions. So one of the things that I'm talking about doing with her is trying to follow up and see if the kids who got into preschool because of this new program and then got diagnosed, whether if you follow them over time, they seem to be doing better than the cohorts who didn't get that early screening and diagnosis.
What about socioeconomic stuff were you able to check whether like children are higher rates of mental health diseases?
So these children are generally reasonably high economic status because they all have good private health insurance, which means their parents have good jobs with good health insurance. What we're doing right now is comparing this sample of children to another sample of children who have public health insurance. And this is very preliminary, but so far the differences are pretty striking. So the children are getting diagnosed with completely different conditions. There's a lot more conduct disorders, ADHD, things like that. And then they are also getting different drugs. So they're getting a lot of antipsychotics, actually, which this group of children isn't getting. So I think there are going to turn out to be pretty stark differences.
So then no.
Hi, and thank you. And I wanted just to get your sense about how severe do you think the impact of COVID would be on these trends, you know, with the long-term impacts?
Yeah, so that's a really interesting question. I think that, you know, the initial shock of COVID was bad for everybody. And there's been a lot of discussion about how mental health of children particularly suffered. I don't think the data is particularly great. So for example, some of the papers which have been published and got a lot of attention would say, oh, there was a big increase in children coming to the emergency room with mental health. Okay, well, if you think about that, where else could they go, right? The doctor office was closed. So now if you have a problem, the only place to go is to the emergency room. Right? So if you only look at the emergency room, you're not getting a complete picture. And so I don't think anybody's really looked at the whole picture. And also whether this was like a spike that came down or whether it continues to be elevated.
Yeah, again, back to the variation in prescriptions across doctors. Sometimes the professional association are supposed to carry out quality control over the doctors. In principle, especially those that are semi-public institutions are supposed to, in a way, guarantee that the services provided by doctors are above a certain standard. And if they don't, they would, in a way, intervene. So I wonder whether you can explain part of the variation by the fact that some of these doctors are members of professional association or not, or whether professional association make any difference in this respect. The second question is instead related to my experience, again, in Italian social security. We were noticing that, you know, even child can apply for a number of disability transfers that are also pretty generous. And there is a clear age bias. So when you get the same type of disease and conditions, if you are a child, if you are way more unlikely. The take-up rate, I would say, is way lower among children. And so we carried out a survey among families with children with these disabilities to ask why this was taking place. Although they could apply, get this money, and could have been used also families with relatively low income. And the answer was that they didn't want to hassle the children going through all the checks, controls, and procedures that are used, because there is clearly a medical assessment, there is a decision to be made by Social Security whether or not they will get the transfer. So, you know, we try to simplify then the procedure to deal with this problem. But I wonder whether something similar takes place also in the context of public support or even private insurance. So there is some underreporting of this type of illnesses by the parents to protect the children somehow. They think to protect them from this traumatic controls and checks that are taking place. And the final is simply a consideration. You know, in Italy it's almost impossible, very hard to carry out research on health data because clearly the privacy authority would intervene at all levels. Even when you act from the standpoint of a public authority and a public agency as a social security, the restrictions are very strong. So you know, I'm looking at enviously at the type of work we've been doing in the US, and I wonder whether similar things, and you know, based on the importance of the findings you had. I mean, I think that what you said should be brought to the attention of the Italian privacy regulator to at least show how important it would be to allow for similar investigation to be carried out in our country.
Yeah, so let me take those questions. Those are great questions. Let me take them sort of in order. So for professional societies, I think that there could be a role for professional societies in sort of enforcing some sort of loose guidelines or professional ethics. In the United States, professional societies do not play that role. Just to take an example, there was a story in the newspaper a couple of years ago which really struck me because it was about this guy in Staten Island who was writing lots of opioid prescriptions. And he eventually was arrested. He was a doctor. He was eventually arrested and disbarred and so on. The reason why he was arrested was because there were so many people outside of his clinic at all hours of the day or night, all these addicts out there, that the neighbors complained to the police. So even though there's a prescription drug monitoring registry, which somebody could have looked at to see that he was prescribing thousands of prescriptions, nobody did anything until the neighbors complained. So, you know, it's unfortunately that kind of enforcement is not happening. Now, another really interesting example, in San Diego, researchers did an experiment where they got the death certificates of people who had died from opioid overdoses, linked that to the prescription drug monitoring registry data so they could see who prescribed the fatal opioids. And then they just sent a letter to the doctor, like, by the way, you might like to know that your patient X that you prescribed this to died of a drug overdose. And then what they could see was that after they received the letter, the doctors prescribed less opioids. Because one thing from the doctor's point of view, I mean, if you think about it as a learning problem, it's actually very difficult for doctors to learn. As a patient shows up, they do something, the patient never shows up again. What did they learn? You know, the patient could have died. The patient could have decided they didn't like the doctor and go somewhere else. The patient could have moved. You know, there's no mechanism in the system to increase learning. With respect to Social Security and children, some research that's been done on this by Manasi Deshpande at the University of Chicago is pretty interesting, where she looks at the fact that basically to be disabled, you have to have some impairment in your activity of daily living. So for children who are supposed to be at school, if they're impaired in their ability to be in school, then they're disabled. But then when they turn 18 in the US system, now their activity is supposed to be working. And that's kind of a lower bar. And so a lot of people lose their disability status when the bar is, you know, well, could you work in principle? And she has a really interesting paper where she's linked the disability data to employment data, but also to crime data. And what she shows is that these people who get cut off, some, you know, they do work a little bit more, but they also commit more crime, because that's one of the ways that you can survive when you get cut off from the Social Security system. So it's a really good paper, I think. And then on the privacy thing, I think you're absolutely right. I wish policymakers had a better understanding of the things that you can do with data, right? So, you know, the typical policymaker is a lawyer, and they're trained to worry about privacy, and they don't know anything about data. So, you know, when you're teaching and you're thinking like somebody in your class is going to be a future lawyer and policymaker, it's really important to communicate the, you know, that there's a benefit as well as a potential cost to making data available for research. Now, the data that I've gotten hold of, I don't want to make, you know, I don't want anybody to think that I just walked into a library and checked it out or something like that, right? So the most of this data, it takes years to come to some understanding with the authority that allows you to use it. And, that's why it's so patchwork. So you have this little bit of data from here, and you have this little bit of data. So you have all these little windows into the system, and there's so much more that you could do if you could link it all together. But as you say, that's incredibly hard. So the project that Rosanna mentioned with New Jersey is trying to get New Jersey agencies to give their data to a third-party data repository, which would link it up and de-identify it for specific research projects. And the people that have been trying to get that off the ground have been doing it for 10 years or something, and now it looks like it might finally happen.
Data that are very important for us as well. We would like to thank you once more for your wonderful lecture and also your availability to answer all these questions. And so thank you so much once more.